once they got sick. That's a big plus. You would do away with the need for competition and probably for much paperwork, because these days that sort of system would increasingly be electronically developed. So it would be a computer-based electronic medical records is what we hear a lot about. So it would simplify things. People in other countries have a card. They go to the doctor and give them a card. The card is swiped, service is delivered, it's paid for, the patient doesn't get a bill but gets the service and goes home. No paper. It's quick, it's efficient, it happens easily. So it solves the moral problem, the ethical problem, gets everybody covered. It diminishes costs dramatically in the sense that those overhead costs are removed. And it diminishes a lot of the administrative costs as well, because the whole thing is simplified. So less paper, fewer people. And it's very clear, I think, that if something like that happened here, there'd be enough money saved to cover the uninsured without driving the cost up.
One concern a lot of Americans have, that in a single-payer system, it's probably true that some of the lower income individuals would have care which do not today, or at least ready access to care. But on the other side, people who have insurance are concerned that their coverage might not be as good under a single-payer system. Is there legitimacy to that point?
Not as much as I think as people would like to put to it, but there may be some. People who have very Cadillac plans now might find that they didn't have the same level of coverage. They might not be able to get a private room, for example, without paying extra. But in terms of the public good, those that have the means who wanted to have extra special services, I can't imagine in the United States that we wouldn't find a way to accommodate that. After all, that's what we're really good at, is selling services that people want. So, but it should not make a difference in terms of effective health care. Obviously, a system like this would have to be carefully watched. It would have to be evidence-based, that is, decisions made about services that are delivered and that are effective would be based on what science tells us about those things. And so that would also, I think, lead to some efficiencies, but it would lead to concern on some that they might not be able to get every service they want exactly when they want it. It's possible. Although I don't think we were likely to end up in the situation that's often decried now with the long waiting lines that Canadians with non-emergent conditions sometimes have, for example. We are overpopulated with services, with gizmos, with MRI machines, X-ray machines, CAT scanners, etc. There would be plenty of room, I think, even if we increased the volume of people coming into this by insuring them.
Is it your position that going to a single-payer system would address some of the biggest problems in America, which include the tremendous drain that medical expenses have on the economy, the illness among those who are currently not covered, the unfairness of people not being able to receive care who have a pre-existing condition? Would the single-payer system address those ills?
Yes. That's the simple answer. Yes, it would. Wouldn't be a very effective single-payer system if it did not. So yes, it would. Perhaps it would be appropriate if our lawmakers, policy makers in this were covered, for example, by the same system the rest of us were. And I think if we were able to do that, then grievances about any future system could be addressed in a very public way. And it's unlikely that if there were any egregious problems that came up with a new system, that they would go unfixed.
Let's address 5 of the myths about health care around the world from an article by T.R. Reid. Myth number 1, it's all socialized medicine out there.
Of course, that's not true. There are only a few countries that are really purely socialized. Britain is one, it's come pretty close. Cuba, of course, is another. But most countries are not completely socialized. But part of the problem comes in the dialogue in the United States that most people don't understand what the word socialized means. When we talk about a socialized system, we're really talking about everything being managed through the government. That is, physicians and nurses and all healthcare providers, folks, are paid by the government. They're employees of the government. The hospitals are owned and run by governmental employees. And services are paid for using basic government funds, usually tax-supported funds, of course. So Great Britain and Cuba are clearly examples of that. And as I mentioned before, we have an example of one of those systems here in the United States, which is the VA system. Others talk about Canada being socialized medicine. Of course, it's not. The payment is socialized, and that it comes from the provinces and the federal government, but all of the providers are private practitioners, and the hospitals are private hospitals. But they agree to a fee schedule with the government, and so when a particular service is delivered, the government is charged, and within 10 days, the providers receive their payment. And those fees are essentially bargained for each year.
Overseas, care is rationed through limited choices or long lines.
Well, yes, people like to point to Canada, our nearest neighbor, and often mischaracterize it. It is true that for elective services, there often are lines. That's one way Canada controls its costs. It does ration it rationally, I would say, by saying people might have to wait 3 to 6 months for a hip replacement, but they might have to wait a month or so for an MRI for something that is not an emergency. If you have an emergency in Canada, then you're taken care of immediately. There's no question about that. Other countries don't have those sorts of lines. Japan is one example T.R. Reid uses, where the Japanese consumer of healthcare uses healthcare services at about 3 times the rate of Americans. They go to the doctor on average more than 15 times a year, and it's just a little over 5 here in the U.S. Yet they spend half per person per year what we do, and they have almost immediate access. Now, that is, many places in Japan, they don't even recommend making an appointment. You just go to the doctor's office. So there are ways, some societies have found ways to minimize this, and the weight issue has been overblown by opponents of change.
Foreign healthcare systems are inefficient, bloated bureaucracies.
Well, it's actually, we're the inefficient, bloated bureaucracy example in the world. We're the worst example in the world of bloated bureaucracy, as I've described previously, because we don't have a system. We have a whole bunch of systems operating within a sort of free-for-all market here that makes us very, very inefficient, so that every other industrialized country is more efficient than us, and some are dramatically more efficient than we are. And we should learn from them if we would be willing to even contemplate that others may have figured out answers to a lot of the questions we're struggling with.
Cost controls stifle innovation.
I think that's a bit of a myth. Certainly the United States is the big engine in medical research in the world and so on, but that doesn't mean that innovation doesn't come from other countries. They have smaller budgets, they have smaller populations, but many of the innovations that we're used to here come from other places. I think T.R. Reid also points out in his book that if you get a hip replacement, that's really a French invention. There are many other examples like that. It doesn't stifle innovation, really. That really is up to the government involved to support government-related research, and to some degree that then devolves into an argument or discussion about drug prices as well in terms of the innovation for new drugs, but that's a separate issue.
Health insurance has to be cruel.
Cruel? No, it doesn't. We're the only place that it's cruel because we allow people to go without coverage, and we allow them to lose their coverage, and we force higher prices on those who are least able to pay.